Good morning one and all. I am Dr. Asmee, Assistant Professor from the Department of Conservative Dentistry and Endodontics from Vinaka Mission Sankaracharya Dental College. Today we are going to say about the cavity varnish, liners and bases. So moving on to the introduction. So prior to placing any cementation or the restorative materials inside the cavity preparation, the clinician must decide if the protective sealer or the liners or bases should be placed on the cavity walls or not. The sound dentin is the best barrier between the restorative materials and the pulp. The presence of the natural intact dentin which minimizes the pulpal response to restorative treatment. Okay, so in this picture you can able to see the presence of the DEJ and the amalgam restorations. Varnish can be applied all along the walls of the cavity. So under this the line you can place any liners of zinc oxide, eugenol, calcium hydroxide material or anything. So the presence of the remaining dentin is very much important. So the greater the thickness of the dentin is related to the reduced pulpal response. Okay, so whatever the amount of the dentin is very much important, so for the preservation of the pulpal response. Okay, so next we are moving on to the terminologies. So we are going to see the three terminologies. One is the affected dentin, second one is an infected dentin, and third one is an RDT, that is the remaining dentinal thickness. So the affected dentin is the hard dentin, so it is yellowish in color. It is a demineralized dentins, but the demineralization can able to remineralize on its own when we place the suitable medicament. Okay, then the infected dentin is the soft leathery dentin. This has to be removed before the placement of the any restorative material. So this is a dark brown in color or black in color. So next one is the remaining dentinal thickness is nothing but the dentin thickness which is present between the base of the restoration and the pulp. So next one, the causes of pulpal irritation. So the chemical irritation is a first and foremost important irritation to the pulpal tissues. So the chemicals from the restorative material that leach out into the dentinal tubules that irritates the pulpal tissues. So next one is the marginal leakage. Then marginal leakage is due to the poor bonding of the restorative materials to the tooth surface. So next one is the thermal sensitivity. Thermal sensitivity is due to the passage of the heat due to the thermal fluctuations when we take any hot or cold drinks. Next one is the galvanic shock or the pain. So galvanic shock or pain is due to the presence of the two dissimilar metals inside a oral cavity which comes in contact with each other. So at that time we will experience the electric shock like pain. So moving on to the next, the causes of the pulpal inflammation. So like other soft tissues in the body, the pulp also reacts to the irritants with the inflammation. See, the pulp is also the soft tissue. So the reaction of the soft tissue is same as that of the other soft tissues of our body. So the primary causes of the pulpal inflammations were the direct toxic effects from the dental materials and also from the bacteria. So when this occurs, the severe inflammation of the pulp is frequently observed. So in that case, we have to do the cavity preparation or we have to do the other mode of treatments. Then moving on to the objectives for the pulpal protection. The pulpal protection, it requires the consideration of the chemical protection, electrical protection, thermal protection, mechanical protection and the pulpal medication. So in this picture you can able to see the chemical protection. So chemical protection by means of placing any cavity varnishes along the walls of the cavity, whereas the thermal protection is nothing but your remaining dentinal thickness, that is about 2 mm of your remaining dentinal thickness is very much important for the protection of the pulp from any insults. Then the mechanical protection is nothing but this is also the presence of any bases or liners or varnishes, and the pulpal medication is nothing but in case of any deeper cavities you can place a calcium hydroxide liner or JC liner or anything in order to protect the pulp. Okay, the electrical protection is nothing but due to the galvanic shock, so you have to avoid the two dissimilar metals whenever it is possible. Moving on to the classification. So there are three types: cavity sealers, cavity varnishes and the cavity bases. The cavity sealers, it provides the protective coating for the freshly cut tooth structure of the prepared cavity. So this has been divided into furtherly varnish and your resin dentin bonding agents. Okay, the varnish is nothing but it is a natural gum, whereas the dentin bonding which combines of primer as well as the adhesives. Next one is the cavity liners. This is a resin or the cement coating of minimal thickness, that is it should be less than 0.5 mm. This acts as a physical barrier as well as it gives a therapeutic benefit to the pulp also. So the example of this cavity liners or the Dical, Life, etc. So next, cavity bases. Cavity bases is the nothing but it is a replacement material for the missing dental tooth structures while we were prepared the cavity preparation. So next one is the cavity varnish. The cavity varnish is used to provide the barrier against the passage of any irritants from the restorative materials, and it also reduces the penetration of the oral fluids at the resin tooth interface into the underlying pulpal tissues or the dentin. Okay, so this varnish also helps to reduces the post-operative sensitivity when applied to the dentinal surfaces under a newly placed restoration. Moving on to the composition, the varnish is the natural gum like copal or rosin or a synthetic resin which gets dissolved in an organic solvents like acetone, ether or chloroform. Moving on to the manipulation of the cavity varnish, so this has to be applied as a thin coating. So this has to be applied by using a small cotton pellet at the edge of the pliers. So it has to be applied all over the cavity walls. So including the margins also you have to apply the cavity varnish, whereas the cavity liners it should not be applied on the cavity margins, okay, because that is a water soluble. So after the first coating of this cavity varnish you have to wait for approximately 15 to 20 seconds. So in order to allow the varnish to dry. So after 20 seconds it will leave, organic solvents will get evaporated and it leaves the thin residues. Then you have to apply the second coating. At least 2 coatings you have to apply on the cavity walls. So this picture shows the application of the cavity varnish all over the walls of the cavity preparation. Applications. The applications of the cavity varnish includes the pulpal protection and the micro leakage. The pulpal protection is nothing but it seals the exposed dentinal tubules, because once we have prepared the cavity, so it will lead to the exposure of the dentinal tubules. So this dental varnish will seal the exposed dentinal tubules, and also it protects the pulp from irritation of the chemicals and it reduces the discolorations around the amalgam margins also. The cavity varnish should be applied before the placement of the zinc phosphate cement, zinc silicophosphate cement, silicate cement, amalgam restoration and the gold foil, whereas it has to be applied after the placement of the calcium hydroxide cement, zinc oxide eugenol cement, JIC cement and etc. Next, it reduces the marginal leakage also. It reduces the marginal leakage especially around the amalgam restoration. So it has an important implications. One is the effective in controlling the inflammatory reaction to the insertion of the amalgam. Next one is it reduces the post-operative sensitivity which is caused by the leakage between the restoration and the cavity wall. The other applications of this cavity varnish includes it acts as a surface coating over the existing silicate cement, and also it reduces the galvanic shock if you place the cavity varnish over any type of restorations. Now we are going to see about the cavity liners. A cavity liner is used like a cavity varnish, so it provides a barrier against the passage of any irritants from the restorative materials, and this also reduces the sensitivity of the freshly cut dentin. Unlike varnish, the liner it provides some therapeutic effects to the tooth. Moving on to the classification, there are 2 types of the liners. One is the thin film liners, next one is the thick film liners. The thin film liners thickness is about 1 to 50 micrometer, whereas the thick film liners is about 200 to 1000 micrometers. So the thick film liners example is that calcium hydroxide, whereas the thin film liners, one is the solution liners, other one is the suspension liners. The solution liner thickness is about 2 to 5 micrometer, whereas the suspension liners is about 20 to 25 micrometers. Composition of the cavity liners is suspension of the calcium hydroxide in an organic liquid like methyl ethyl ketone or the aqueous solution of the methyl cellulose. The other system which also includes the 2-phase system, that is example Dical, that is a calcium hydroxide cement which includes a base and the catalyst tubes. Next one is the single phase system along with the solvent, whereas the other one is the single phase system. Moving on to the manipulation of the cavity liners. So the cavity liners which are fluid in consistency and it can be easily flowable and it can be easily painted over the dentinal surfaces, cut dentinal surfaces. The solvent gets evaporated and leaves a thin film residues that will protect the underlying pulpal tissues. Moving on to the properties of the liners. So like varnishes, the liners it neither possesses the mechanical strength nor the thermal insulation. So the compressive strength of the paste material, that is Dical, example is the Dical material at 24 hours is about the 12 to 23 megapascal. For Cavitec, it is approximately 5 megapascal strength, and the calcium hydroxide liners are the soluble, so it should not be applied at the margins of the restoration. Moving on to the zinc oxide eugenol liners. zinc oxide eugenol liners are noted for their palliative effect over the pulp. It has a sedative as well as the obtundant effect. So it is considered as the least irritating to the pulp of all the materials which is used in the cavity restorations. Next, move on to the contraindications to the use of the zinc oxide eugenol liners. So it is contraindicated under the composite restorations because the eugenol which is present in the zinc oxide eugenol, it prevents the polymerization of the resin. So next one, it should not be used under the GIC restoration also because it may cause the discoloration of the restoration. Moreover, GIC, it bonds chemically to the tooth structure. If we place the liner, it will not, the chemical bonding will not occur. Moving on to the calcium hydroxide liners. The calcium hydroxide, it seems to be the material of choice for the prophylactic pulp capping in cases of the microscopic or the near pulpal exposure. So however, the main purpose of the cavity liners is to use the beneficial effects of the calcium hydroxide which accelerates the formation of the reparative dentin from the pulp. Moving on to the glass ionomer liners. This glass ionomer liners can be used as a cavity liners. It has two desirable properties. One is the chemical bond to the tooth structure and another one is the fluoride release. So the fluoride release can be decreases over time and this also has an anti-cheiroogenic activity. So the fluoride recharge has to be done using any fluoride toothpaste. So this glass ionomer restoration will take up the fluoride from the toothpaste and it will increases the anti-cheiroogenic property. So the exact mechanism in which the glass ionomer reduces the bacterial invasion is uncertain, but it may be due to the one or more of the following. One is due to the fluoride release or initial lower pH, or it bonds chemically to the tooth structure, so physically excluding the bacteria. The glass ionomer liners are indicated in routine cases of the composite restorations where there is no danger of pulpal exposure. So the primary purpose of the glass ionomer liner is to act as a bonding agent that adheres to both the dentin as well as the composite resin, so aids in sealing the cavity and retaining the resin restoration inside the cavity. So the glass ionomer liner provides a protection from secondary caries. So this technique is referred to as the sandwich technique. It is particularly useful when the margins of the cavity are located in dentin, such as in cases of class 5 and the class 2 restorations. So in this picture you can see the placement of the GIC restoration and the composite restoration has been placed over this GIC restoration by increments. There are two types of glass ionomer liners available. One is the conventional powder liquid system and other one is the light activated glass ionomer cement. So moving on to the cement bases, it is a layer of the cement which is called as base is placed under the permanent restoration to encourage the recovery of the pulp and to protect it against the several types of insults. Moving on to the classification of the cement bases. So according to the strength, it can be divided into low strength bases and the high strength bases. Under this low strength bases, the examples are the calcium hydroxide cement and the zinc oxide eugenol cement. This can be used as a pulp capping agent. Whereas in case of high strength bases, you can use the zinc phosphate cement or zinc polycarboxylate cement or GIC. So these will provide the thermal insulation, electrical insulation and mechanical support to the overlying restorative materials. According to the chemical nature of the cement, it can be divided into acidic, neutral and alkaline. Acidic is GIC and zinc phosphate, whereas neutral is the zinc oxide eugenol cement, whereas alkaline is the calcium hydroxide cement, zinc polycarboxylate cements. The following are the guidelines for the placement of the bases. So this has to be used as minimum as possible to achieve the desired result. This should not exceed 0.5 to 0.75 millimeter under the amalgam restorations. So next is the direct pulp capping method. So the direct pulp cap should only be attempted when a small amount of mechanical exposure is there, that is less than 0.5 millimeter. So often otherwise healthy pulp occurs in an isolated environment. It has to be done under rubber dam isolation. The exposure should be covered with the calcium hydroxide because of its documented ability to provide the highest percentage of success. Next is an indirect pulp capping. So all the caries is removed except the last portion of the firm leathery dentin immediately overlaying the pulp, which might result in the pulpal exposure if excavated. So the placement of the calcium hydroxide over this layer of the infected dentin is shown to virtually eliminate all the remaining bacteria and render the residual caries dentin operationally sterile. So in this picture, the first picture it shows the direct pulp capping procedure, whereas the second picture it shows the indirect pulp capping procedure. Okay, so the direct pulp capping procedure, you can able to see a small amount of exposure of the pulp over here, which is less than 0.5 millimeter. So over this you can place any liners, that is mostly the calcium hydroxide liners are preferable. You have to place the calcium hydroxide over this exposure site, and over this you have to place the other restorative materials. This is the direct pulp capping agent. This has to be done under rubber dam isolation. So under sterile environment, if the pulp gets exposed only, you have to do this direct pulp capping procedures. Otherwise you have to go for pulpectomy or the pulpotomy procedures. So the second picture, it shows the indirect pulp capping procedures. So you can able to see the soft leathery dentin here. This should not be removed. So if you remove this soft leathery dentin, so you will expose the pulp. So you have to leave this leathery dentin in its place, and over this you have to place the calcium hydroxide material and the restorative material. So this placement of the calcium hydroxide, it will entomb the remaining bacteria inside the cavity. So finally, I will conclude that understanding the properties of currently available materials and how they interact with the pulp tissues, it can help the practitioner to decide when to use the bases and liners and which products to choose. Thank you for listening my class.